You have co-hosting powers, Josh?
Excellent, excellent, great.
Recording in progress.
And David Thomas is just joining us, so he will be here too.
Awesome.
Good morning, David.
Morning, Jay.
We can give it one more minute, folks, and then we'll get going. Okay, folks, we are going to get started again as usual. Please keep yourself on mute. We will have a question and answer period after we hear from Dr. Labair, who will talk about COVID trends in Arizona, and from David Thomas, who can speak to the vaccination, public vaccination that ASU is involved in at sites around the state of Arizona. So we'll have comments from each of those gentlemen, and then we will turn it over to questions. And we will begin, as we always do, with the Executive Director of Arizona State University's Biodesign Institute, Dr. Joshua Labair.
Hi, good morning, everybody. Right, so I'll start by just commenting a little bit about where we are in terms of overall frequency of cases. And as you all know, we've come down significantly from a pretty high peak earlier this year. Now, we've come down, but we seem to have stalled. Our 7-day trailing average is still a little bit north of 1,000 new cases a day. I would personally love to see us get well below that, but we're sort of stuck at about that level. The last couple of days has been below 1,000, so let's see if that number could come down a little bit, but that's where we've been at. Nonetheless, hospitals are looking much better. There's certainly availability for beds. They're not as heavily occupied by COVID-19 patients, as is true for the ICUs. There are also a lot more beds available for folks for other purposes. So that's certainly encouraging. In terms of things that we're tracking here at ASU, one of the things that we're noticing is definitely a rise in the number of Esgene dropouts. You could think of that as this UK variant of the virus. I'm going to share one graph today, so I'm going to pull that up right now. So let me just get my screen sharing going here. So this graph is now available on the ASU website. And as you can see in the, over the course of the fall, there was sort of a trickle of folks with these Esgene dropouts, but that number has risen considerably in the last couple of days here, last week or two. It's going up quite a bit. And the fraction of positive cases due to this UK variant is much higher in Arizona than it used to be. So that will be something that we want to follow. We've also seen a rise in what's called the California variant that is also observed here in Arizona. And the question will be, and Arizona will be the experimental state for this, I think, whether the Esgene dropout overtakes the California variant. We don't know yet. We'll see where that goes. I will mention a couple of things about the UK variant that we should keep aware of. One, it is definitely much more transmissible than other forms of the coronavirus. And there's a paper out today that demonstrates that it is more deadly. So there's been some discussion in the past weeks that it looked like it might be more deadly, and that seems to be verified by a head-to-head study where they compared patients with the UK variant to patients who didn't have the UK variant in the United Kingdom, and found that the UK variant is more deadly. I will follow that immediately by saying that the vaccines we're using in the US, all three of them, protect against the UK variant. So it will be effective against that variant, but it does suggest the possibility that if this new and much more transmissible variant gets a foothold in Arizona, it could start to multiply and we could see another surge resulting from that. It'll be a little bit of a race between getting the vaccine in arms and how quickly that variant starts to emerge. And so we'll want to keep an eye on that, see where that all goes. In terms of vaccination in the state, we're around 10% fully vaccinated. If you combine that with what we suspect will be about 20% of people who've been infected, that means about 30% of people in the state of Arizona are resistant to the virus at this point. It also means that roughly 70% of the people in the state are still susceptible to virus. And so when people are out and about, we would still recommend mask wearing. The CDC guidelines are still pretty clear. The CDC still recommends that this is not a time yet for big gatherings, for visiting stadiums, for sitting in crowded places indoors. They still recommend against that because so much of the population remains at risk of infection, recognizing that some fraction of people who get infected will get ill, severely ill, and potentially die. So those are things we want to be aware of. This week is also notable because the CDC did come out with guidelines for people who are fully vaccinated. There is some good news there. Among those guidelines are that people who are fully vaccinated are free to interact indoors at length without masks with other people who are vaccinated. So people who are fully protected can interact with each other without any concerns, and they can do that indoors. So that's good news. They also recommend, the CDC, that people who are fully vaccinated can visit individual households where others are not fully vaccinated, as long as the people who are not fully vaccinated are not at significant risk of bad outcomes. So for example, grandparents can go visit their children and their children's children if they're young adults and or children who are not likely to have a severe outcome, not at risk of severe disease. So the CDC does not recommend bringing a lot of families together. So grandparents visiting one family at a time is great. Bringing everybody together for a big family reunion, not yet. There's not the time for that yet. So it's really, but it is encouraging that with the vaccination, folks can start doing some things. All the other guidelines are still the same. CDC still does not recommend big groups, big gatherings, even if you're vaccinated at this point. If you have to go out, they still recommend that people who have been vaccinated wear masks. A couple of other points related to vaccines, probably worth mentioning. So I still get asked questions about, is one vaccine better than the other? And my answer is that the best vaccine to get is the one that you can get. They are all excellent. Virtually all three of the vaccines in the US prevent death. As far as I know, people who've gotten fully vaccinated have not died from COVID-19. It prevents ICU infection or severe infection. So they have excellent protection for the things that matter the most, which is severe illness. All three of them do. And really none of them is better than the others. One could argue that the J&J vaccine has the advantage that it is a one-dose vaccine. And so once you get vaccinated, within about 2 to 3 weeks, you will be protected and you will be done. You don't need to do anything else at that point. But they're all excellent vaccines in that regard. There is some evidence that with these vaccines, a small fraction of people could still pick up the virus. Not many. It's significantly reduced, the risk of infection, but you could still get infected. And that's why we still recommend mask wearing, because you could transmit the virus. You yourself will probably not get severely ill. In fact, almost certainly not get severely ill, but you could transmit the virus to others, which is why they recommend mask wearing if you're with large groups of people, because there's a chance you could be a carrier. So that's something to pay attention to. I think that's most of what I have to say. Maybe there'll be some questions about some of that. So, but before I do that, let me hand this off to Dave, and he can give you an update on where we are in the state.
Sounds good. With that, David Thomas is the Chief Executive Officer of ASU Research Enterprise. That's his old job. He frankly now is the site manager and operational guru at the public testing sites on behalf of ASU. So, David.
Thank you, Jay. Thank you, Dr. Labair. So just some quick numbers just to keep everybody updated. The large mass vaccination sites are running quite smooth, continue to have excellent throughput. Right now at State Farm Stadium, as of 10 o'clock this morning, we crossed over 444,000 since opening. And then at Phoenix Municipal Stadium, 87,000, bringing the total for those two sites to over 531,000. So over 500,000 people vaccinated at those two sites alone. The throughput continues to remain consistent at State Farm Stadium. We're running about 440 an hour. At Phoenix Muni, about 385 an hour. And so that means that there's a dose given about every 8.7 seconds at those two sites. The Phoenix Muni is still limited in terms of vaccine supply, so we're able to provide what the state can give us in terms of the vaccine. Definitely looking at considerable planning to accommodate the heat. As we've seen just within the last few days, we've had highs in the 80s, and that has been noticed certainly by the folks on the ground. So we're looking to, at indoor locations throughout the valley, and be making transitions into more indoor locations as we proceed forward. Still working also on supporting and scaling sites in rural communities, including underserved communities, and hope to have something that we can talk about that's concrete in the next week or so, but those plans are moving forward, and lots of interest and lots of support from many different constituent areas. And so with that, I believe I'll conclude my report, and Jay, hand it back to you. Thank you.
Thank you, David. Questions from the group? Please let us know who you're with. Thank you.
Hi, Dr. Labair. This is Daniela with Univision. Hey. How are you?
Good. How are you?
Good, Dr. Labair. This is a year since you guys started these Zoom meetings, and we have seen what happens every time there is a holiday, Memorial Weekend and so on. How concerned are you right now with the spring break? And
right.
And can you tell us a little bit of history of how this has come? Because I think people need to have some perspective on that. Some people say, oh, I'm vaccinated, it's okay to go. So could you please, explain to us the history of that and the danger that this could quickly change because people trust that everything is okay?
Well, I think that we have to keep remembering that this virus historically has come in waves. We see that the numbers go up high, then they come down, and then not too long after they come down, they do start to rise again. We saw this huge wave over the summer. They came down to very low numbers in September, and then they kind of crept back up again through October and November until we had that really big surge in January that was pretty devastating. Keep in mind that even though it's come down now, it did not come down to the levels it was in September. It came down to levels in mid-November. So kind of well on the way to a big surge already. So we're starting at a much more disadvantaged position than we were in September, for example. So we do have to watch out for that. And we have to remember that 70% of our population remains at risk of infection. So those are the concerning things. That said, there are vaccines going into arms, and we are especially focusing on giving vaccines to people at risk of severe outcome. So we are hitting the older population, which has been disproportionately hurt by the virus. The hope would be that by doing that, we'll prevent some of those people from ending up in the hospital. But, as the CDC says, this is not the time to start doing a lot of big public things. It's not the time to start getting together in groups. we really need to reach that herd immunity, which we hope will hit sometime in July, that would prevent an outbreak. And that's when we could really feel much more relaxed, I think, about interactions and such.
Dr. Labair, and a follow-up questions, because and this is an experience we have from every single holiday, and is despite the warnings, people are still going to travel. So is there less risk to travel by car versus traveling by plane? What people should do at this point if they travel? They get tested before, they get tested after. If you can give us a little bit of more recommendations, because I'm afraid that as much as we are like a broken disc saying, please do not travel, people are going to do it. So could you please explain what is the level of risk between the different forms of travel and what to do if they decide to travel? Thank you.
Right. So, I think I would agree. It'd be best if we don't travel right now. But if you do have to travel, keep in mind that the biggest risk is sharing air, right? That's how we transmit the virus is through air. So if you're in a closed space for long periods of time, then you're sharing air with other people, and there's a chance you get infected. So things like being in a bus for a long period of time or being in an airplane for a long period of time runs the risk. Now, you can significantly reduce that risk by wearing a mask. And probably the most important thing to remember is that if you are indoors for a long period of time with people that are not in your immediate family circle, as in an airplane, as in a bus, anything like that, then you should be wearing a mask, and you should make sure that the mask is fit well so that it seals well above the nose and around this rate. You want to breathe air through the mask, not around the mask. So make sure you're wearing that when you're confined. And then, of course, as quickly as possible, if you get to the station or the airport, spread out, get away from other people for now. Keep your distance. The farther you are from people, the more space there is, while still wearing a mask, the lower the risk. So those are things. Of course, I wouldn't be eating on airplanes where you have to take your mask off to do that. It's all about preventing the infection.
And about the testing, because, people say, oh, I take the test and then I'm good to go. But then on the way back, oh, I get tested right in the airport and then I'm okay. So CDC says 3 to 5 days after you arrive. And if you can explain a little bit more about that part.
Right. Well, it's important to know that if you're exposed on an airplane, your test will not be positive that day, the next day, the day after that. The test won't be positive for up to about 3 to 4 days after the exposure. It takes that long for the virus to appear in your bloodstream and eventually make its way to your mouth and nasopharynx or to your saliva or however you do your test. So it's really, and we've seen this over and over again where people have been exposed, they get a test immediately thereafter and it's negative, and then several days later they get COVID. So you really want the ideal time to test after a possible exposure is around 4 days. That's when I would get tested. And of course, always monitor for symptoms. If you get symptoms, that's a sign that you're infected. And that's even true for vaccinated individuals. The CDC is now saying that if you're vaccinated and you go traveling and you're exposed, you don't necessarily have to get tested unless you get symptoms. But if you get symptoms, even people who've been vaccinated should get tested.
Thank you.
Sure.
Hi, Dr. Labair. Piper Hansen from the State Press. I was just wondering if you could go back to the Esgene Dropout data and explain that one more time.
Sure.
I think I have a question, but your explanation might answer it.
All right. So first of all, I'm showing you the graph again. These are the Esgene Dropouts. Now, Esgene Dropout is a characteristic of the test we run at ASU that measures 3 genes from the virus, one of which has been altered in the UK variant. And what it does is it causes that gene to not be positive in our test. The other 2 genes are still positive. That pattern usually correlates with the UK variant. There are a couple of other variants that have that pattern, but they are much less common. And what you're seeing in these data is in the last couple of weeks, really, a kind of increased rise in the fraction of tests that are positive due to this UK variant, which means that it's increasing in its prevalence among the other strains that are present in Arizona. And so that's what's going up right now. Did that answer your question?
Yes, it does. Thank you. I do have another question I wanted to ask, which is, as I'm sure you know, the executive order from, I believe, last Friday from the governor reversing the occupancy limits. I was just wondering if you think that that will have an impact or a large impact on the spread of the virus in the state or within isolated communities like a college campus.
Sure. Well, as occupancy goes up and people are not wearing masks, there will be an increased risk of spread. Right now, the prevalence of virus is low, but it's important to remember that, with a virus like this, initially you don't really notice the growth because it's an exponential curve. And eventually, though, it can start to take off. And so there is certainly a risk right now, since 70% of our population is not resistant to virus, that the virus could spread, especially if we have growth of these, the UK variants and possibly the California variant, which are a little bit more transmissible. There is the risk that we could start to see spread. And of course, important thing to remember here is that for people who visit restaurants, their risk is going to be the time of their exposure while they're at the restaurant for the hour or two that they're there. I have a concern for the people who work in those restaurants because those employees are exposed throughout their entire shift. And so for those folks, they should certainly get vaccinated as soon as they can. And they should certainly be wearing masks for the entire duration of their shifts because they are personally at risk of getting infected, and they should get tested regularly. I would recommend getting tested once a week to monitor to make sure that they don't get infected because, for them, it's an occupational hazard to be exposed to the virus all the time.
Maybe your question did lean into another topic that I want to address for you and for others who may be here. You mentioned college campus. Important to note there are no change to protocols at the university at ASU. Distancing, face covering, people gathering in groups, all of those remain as they have been. So we're not making any changes at the university based on the relaxation in the executive order from the governor last week. Sunday fitness will continue to be by appointment only. Dining protocols will continue to be what they've been for the entire semester. So.
Yes, thanks, Jay. That was my next question.
Right. We are still holding in-person classes, but wearing masks with proper spacing, all of those sorts of things. So, we're following all those guidelines.
Dr. Labair, sorry, Jay, please.
Please, no, go ahead. Yeah.
Thank you. Dr. Labair, Garrett Archer with ABC 15. Going back to the Esgene really quick. Several weeks ago, you had said that there's a potential for the UK variant to be the dominant variant in Arizona at some point. Do you think we're still on that trajectory? And if we are, what does that do to our herd immunity calculation? Does that bring us closer from, does it bring us earlier than July? What do you think it does to us?
Right. That's a really good question. So, the first, yes, I do think that the numbers suggest that as the UK variant is growing in our mixture of variants within the state of Arizona and becoming at least a little bit more predominant there. It's not predominant yet. It's still a minority, but it is growing. And in a sense, we are going to be a test bed, our state, because we also have this California variant, which is actually currently more prevalent than the UK variant in the state. The question will be, will the UK variant overcome the California one? And the data will have to show what happens with that. What that means in terms of herd immunity, or the herd immunity calculation, which is a calculation that asks, what fraction of a population needs to be resistant in order to prevent an epidemic spread? In other words, how can we do enough people vaccinated or resistant such that the virus can't start a chain reaction of infections within the population? And part of that calculation depends on the transmissibility of the virus. The calculation that was, suggesting roughly a 70-something% of people need to be vaccinated was based on a less transmissible virus, the strain that we had in the fall and in the summer. The UK variant is more transmissible, which means we need to reach a higher number of vaccinated people to, again, prevent that chain reaction. Because the UK variant is more transmissible, it is more likely to start a chain reaction. So, we might need to get closer to 80% vaccinated than 70% if the UK variant becomes dominant here.
And do you think July is still the threshold, or does it sort of change the temporal nature of everything?
Right. It does look like, based on the rate of vaccination right now, that sometime in July, mid to late July, we will be in that herd immunity range. That's the best projections I've seen. Obviously, things can change, and hopefully, if for example, a lot more of the J&J vaccine gets out, and because it's a single dose, you can reach more people more quickly. All those things could make it go faster, we hope.
Thank you so much.
It's also why David Thomas is trying to find indoor distribution centers.
Right.
Other questions? Okay. Well, we'll be back here next week. We will do this again and take a look at where we are at that point. Thank you all for joining us. We do provide a recording of this afterwards. If you didn't have the chance to do that, you want one, contact me or Sandy Leander. We'll get that out to you. And other than that, we will, any follow-up also available for that. And then we'll see you next week. Thank you all.
Take care.
Recording stop.